buildup of dead skin, which in most people would die and shed and migrate naturally out of the ear. But in the cases of people who suffer from keratosis obturans, this dead skin that dies and sheds in your ear canal doesn't naturally migrate. In most people it migrates, it moves sideways like a conveyor belt out of the ear, but instead it forms layers of dead skin in the ear, which then form a plug, and this plug of dead skin just gets bigger and bigger and bigger, expands in the ear canal to a point where it can be extremely excruciatingly painful for the patient, and it can also cause expansion of the ear canal, widening of the bony part of the ear canal. And so the patient has got keratosis obturans, but they've also got an infection, there's a bit of otorrhea, discharge. The ear canal is also inflamed, swollen. So just using microsuction just near the entrance, just trying to clear the lateral debris, so this infected debris as well. So it's not only a skin plug, but we've got all this debris due to the infection. So we're just slowly but surely clearing that away near the entrance. And we're probably about, where we are now is what we call the osseo-cartilaginous juncture. This is where the cartilage portion of the ear canal, so the outer third of the ear canal, meets the bony part of the ear canal, so the inner 2/3. And this skin plug, this keratosis obturans, has got trapped here. So keratosis obturans typically, it occurs more in the bony part of the ear canal, and it's expanded, it's got so big, the plug, it's widened the ear canal, and it's causing what we call contact bleeding. So when I'm trying to peel this and manoeuvre this plug off the posterior canal wall, so the back part, you'll see, because the skin is that tightly adhered, there's a bit of blood seeping out. So it's nothing that we've done, we've not grazed the ear in any way. It's a hallmark of keratosis obturans. And when you get a bit of bleeding in the ear canal, we typically grade, keratosis obturans has different grading systems. Grade 1 is the mildest form, grade 4 is the most severe form. When you've got a significant widening of the ear canal and a bit of bleeding, we would grade that grade 3 or grade 4. I would say this is more grade 3 than 4. And you can see here, I'm just trying to manoeuvre this plug, the skin adhesions. And you can see the ear canal's narrow, and it's widening, and that's due to this keratosis obturans. It's expanded the ear canal, it's widened it. So it was quite difficult to remove. And one of the characteristics of keratosis obturans is that dead keratin like this is quite spongy. It's got a lot of kinetic energy. So just going in with the ear hook, we've got to be really gentle because we are on the bony part of the ear canal. So I'm not getting too far with suction, so I'm just trying to embed this into the plug. And sometimes you bring it forwards and it comes out in one big plug, but here it's dissected it. It's like a hot knife through butter. Nonetheless, it did help me to perform microsuction still, because it's almost decompressing this plug. So this plug has got so much compression, just by slicing through the core of it, it relaxes the plug of skin, and it does help with microsuction. And I'm just going back to the suction. I'm just trying to create some space around the edge, because in a moment I'm going to put some sodium bicarbonate drops in. Sodium bicarbonate drops works quite well with dead skin keratin, as opposed to olive oil. So if it is earwax, I generally resort to olive oil. I use a spray, but if it's keratosis obturans or any form of skin, sodium bicarbonate drops I feel works a lot better. It's far more effective. And so because of the infection as well, the ear canal is quite narrow. So we're using a standard Zollner suction probe there, and it was more or less taking up the entire space of the ear canal. So I've just put some sodium bicarb drops in, left it in for a few minutes. So I've just gone back in with the suction initially. And another way to describe this, it's almost like chewing gum. A dry chewing gum at the bottom of your sole and your foot. And what made the patient came as an emergency today, couldn't sleep last night. So again, one of the hallmarks of keratosis obturans is severe pain, and it kept him up all night. And as soon as we opened the clinic this morning, we had a phone call, and we managed to get him in as an emergency today. And so I'm really tugging away at it. So in a moment, we're going to use hooks and forceps. It's always a bit difficult introducing hooks and forceps deep into the ear because you just want to avoid making contact with the bony part of the ear canal because it will be very uncomfortable for the patient. But we had no other choice really. So you can see from the plug, the outer part of the plug, you've got the fresh dead skin, so that's white in appearance, and then as you go to the middle of the core it gets darker, so you can then it's almost like a rainbow effect or different shades of yellow. The outer part it's white, fresher skin, and in the middle that's the older skin, and that's oxidized, so it's a darker, it's almost brown, and you can see the change in colour. You've got some really strong skin adhesions here that are attached to the ear canal. And here's that contact bleeding just here on the right hand side. So the plug is expanded so much, it's widening the bony part of the ear canal, it's compressing against it. If you watch my YouTube channel, there's a playlist of other cases of keratosis obturans. In comparison, this is keratosis obturans is always complicated to remove, but I've had far more complex cases than this. So I've just gone in with the fine jaw crocodile forceps. I've managed to get the bottom jaw, the bottom of the plug of skin, so that's why I was lifting it with the suction probe just to make a bit of space there. But because of the consistency of this dead skin, it's quite it's soft, it's stretchy, and the forceps are in some way just cutting through. It's not extracting the plug, it's just slicing through it like scissors. So I think I'm going to go use some ear hook now. So I'm just trying to get underneath the plug into the middle and then rotate, and then I'm going to bring the hook slowly forwards. And I just dissected some of this dead skin, so although it didn't come out, I can now go back in with the Zollner suction probe and vacuum this away. So quite often when you're performing procedures like this, you're using the micro instruments, the ENT micro instruments in tandem. You're using one to support another, and you use them in a sequence to help remove the wax. It's not that we're just going to use one procedure, one instrumentation, one tool and stick with that. So we're just on the anterior canal wall. This is to the front part of the ear canal. So the front part of the ear canal in the left ear is to the left, in the right it would be the right. And I've got a suction grip and I'm just wriggling this skin, trying to detach it, elevate it off the canal wall, so almost break the skin adhesions that are keeping this plug firmly in situ. So gone back in with the hook, and I'm just trying to glide in underneath and to the front part of the ear canal. And again, I'm just trying to push this skin away from the back part of the ear canal just to loosen it. And again, so I've not attempted to remove it, I've just wanted to break it up a bit, disrupt the surface, back in with the forceps. Again, I'd managed to get a slither of dead keratin out skin, but it didn't start coming out in big lumps. But we're just going to persevere. Now you can see the widening caused by this keratosis obturans. So the ear canal here, it's expanded because of the plug, it's widened, it's stretched the ear canal. So it's very likely that this patient will need to have their ears cleaned on a regular basis, because when you've got a widening of the ear canal like this, it's not uncommon that's for skin that's shedding off the eardrum and the deeper part of the ear canal to get trapped in the widening. So this plug is probably halfway down the ear canal, so it's still quite extensive, and I'm just gliding the hook in posteriorly, and again just be really gentle and careful with a steady hand to avoid contact with any part of the ear canal there. And again, I'm just breaking this up into little pieces. I'm going to go back in with a suction probe, I think. We shall see. There we are. And again, there's very little room for manoeuvre. So this is the full standard size Zollner suction probe, and it's taking up much of the ear canal. We've just got an amazing, fantastic view. This is the endoscopic view. It's unrivaled, unparalleled compared to any other visualization technique available, whether it be an otoscope or a microscope. You just don't see this. You don't get the same view. And for me, the view is so critical because it helps me not only visualize the earwax safely, and it also tells me which part of the ear canal I'm in, but it enables me to manipulate the plug of wax. I'm treating the plug of wax or skin as one. Quite typically with other visualization techniques, your view is quite narrow, so you're only seeing part of the plug, and therefore you may not be manipulating it in the correct way to bring it forward. So I create a gap in the middle, so quite deep now, probably about half a centimetre to a centimetre away from the eardrum. Delicately inserted the tip of the hook into the gap, and I'm just rotating it, just slowly loosening it off the canal, nice and gently. I managed to bring that one forward. There is some granulation tissue there as well. So granulation tissues, when you've got trauma to the ear or the other parts of the body as well, not exclusive just to the ear, during the healing process you get a build-up of connective tissue, so we call that granulation tissue, and that connective tissue also develops its own blood supply, and you get a rough, fleshy appearance. Sometimes when you're doing suction, you can suck the granulation tissue out of the ear. Quite often it's cauterized by ENT doctors. They use silver nitrite and they cauterize it, so essentially burning that connective tissue, preventing it from growing anymore. And once you've burnt it, the ENT doctor's hoping that you'll get a normal regrowth of skin as opposed to the granulation tissue. So at this stage, the patient's symptoms are more or less alleviated. The sound can get through, the pressure has been relaxed because you can see we've broken through the plug. In the distance we've got the eardrum. You'll have a close-up in that in a moment. We've still got quite a lot of skin here, and it's trapped. You can see the swelling around this. Again, with keratosis obturans, not only does it cause a widening of the bony part of the ear canal, sometimes you do get a swelling of the ear canal which engulfs this plug of skin into the ear. So we're going into the ear, it's widened, there's the expansion. You can probably got a really good view of that, where the ear canal's widened, and then it's narrowed again, it's swollen here. So I'm just using forceps, just trying to release the skin, trying to peel it off the back part of the ear canal. I'm being careful not to clamp, that's the word, the forceps, because I don't want to cut through the skin. I just want to have a bit of purchase, a bit of grip, so I'm being quite gentle when I'm closing and clasping the forceps. I'm doing it really slowly, just trying to wriggle, loosen it. The patient's been referred to their GP to get some medication for this. I've also, with keratosis obturans, one of the things I advise patients who suffer from it is to use sodium bicarbonate drops either on a weekly or fortnightly basis, just to soften this keratin. It's not going to really stop it from forming again, but it does soften it. So when it comes to removing it, extracting it, it's far easier. So then I'm going to use the suction probe again. You can see with the sucker there's very limited space there. It's just blocked the suction probe. I'm just trying to peel it off the front part of the ear canal. And then I think I'm going to go to the roof of the ear canal and peel this plug of skin downwards. There we are. So I've just gone to the top. I'm going to come down on it. You can see some of that infection, some pus there, some granulation tissue underneath. And you'll have a better perspective in a minute of the swelling. You can see the swelling on the left-hand side and the top of the ear canal, which has engulfed this plug. And the skin is like double-sided sticky tape. It's really strongly adhered to canal wall. So we can just see the hammer bone of the eardrum there, and you will get a close-up in a minute. Just see the inflammation here, the edema, the swelling of the ear canal. If you look to the right, you'll see that little blood mark just to there on screen. So that's where the plug started off. If you remember, when I was initially removing that plug and I was trying to lift the plug off the back part of the ear canal wall, we were getting that contact bleeding. So you can see how deep we've had to go, how extensive this plug was, how deep it was in the ear canal. You may see that because the patient's ear is infected, there's increased temperature, humidity in the ear, which we get a bit of condensation on the lens of the endoscope. As soon as you're going with a suction probe, that condensation disappears, it evaporates. If I just left the endoscope in the ear for about 30 seconds, it itself would remove the fogging and misting and the condensation. There's quite strong adhesion there, so I've just lifted it off the canal wall. There's something for me to clasp onto and grab onto, so I'm going to go back in with the forceps. Just going to be careful because we're really close to the eardrum now. We don't want the tip of the forceps, which is the pointed bit, to make contact with the eardrum or the ear canal wall. And there we are. I've managed to remove that last slither of dead skin. So the patient's been advised not to use cotton buds, not to get water in the ear, written to their GP to get some medication for this, and after which they're going to use sodium bicarbonate drops on a weekly basis and attend in 6 months just as a routine appointment as a follow-up. So just some dead skin here. Just want to see if that will remove, but it won't. You're going to get close up to the eardrum now, so we're going to go really deep into the ear. Again, just going to make sure that the endoscope itself doesn't touch the ear canal. There's the eardrum, slightly inflamed because of the plug of skin, otherwise it's functioning fine. Well, I hope you enjoyed that video, guys. It was interesting and it gives you a perspective of what's going on with the keratosis subtrans, because you've got a good view here of how it widens the bony part of the ear canal and then you get swelling that engulfs it. And also because it's infected as well. You can see all the colour of the ear canal. It's quite spongy, it's swollen, and it's inflamed. Well, keep well and safe and stay